Welcome to the January 2024 quarterly Arkansas APCD Data Users Group. This is our 18th. I always am proud of that. And one note, the Arkansas APCD and Healthcare Transparency Initiative is fast approaching its 10-year anniversary. 10 years we've been doing this and having fun. For those of you who are new to these sessions, I see a lot of repeats, so bear with anything you've heard already. For those of you who are new, the Arkansas APCD is part of the Arkansas Healthcare Transparency Initiative, the ACHI. You'll see that periodically in these slides, and is administered by the Arkansas Center for Health Improvement, ACHI, ACHI. The Arkansas APCD is comprised of private carrier and public payer medical, pharmacy, and dental claims, as well as enrollment and provider data. Additionally, the HTI enables the use of key data sets from the Arkansas Department of Health, including Arkansas Vital Statistics data, birth certificates, death certificates, hospital discharge and emergency department data for those labeled as self-pay or uninsured, cancer registry data, some medical marijuana card holder data, and some Arkansas workers' compensation data from the commission, not employers. We hope that you find today's session helpful. Some housekeeping rules before we move forward. Feel free to type your questions in the chat at any time, and I'll address them as I can. I am running the ship by myself, so I will keep an eye out. Be patient. At the end of today's session, probably it'll be tomorrow, but we'll provide a link to the deck and our service desk application. If you have questions, you'll get an email with the recording and any links to the website that you need. Additionally, well, with that said, let's move forward to the next topic. This is the agenda for today. It's mildly light. I find that even if it's light, we can fill the hour. But here we go. The topics are linking external data files to the Arkansas Transparency Initiative data. Oh, I'm sorry. Went ahead. Data use cases from other APCDs. Always fun to see what they're doing. And latest release information, and spoiler alert, we're getting refreshed Medicare data, and I'll give you some details then. If the meeting runs short, then I'm going to ask anyway at the end, if you have any ideas for a topic for a data users group, then please send them to us. We can chat about it at the end. You can send it to us in an email. You can put it in the chat. If there's something in particular that you are interested in, a lot of users delve into cancer registry data and Medicare data. Maybe we need something focused on that. So all ideas are welcome. I'm your only speaker today. My apologies. I don't have a guest speaker this time. Hopefully I can carry the load. We will have a guest speaker for the April session, and hopefully all the others too. So let's get started. The topic is the featured topic is linking external data files to the Arkansas Healthcare Transparency Initiative. I'm going to turn my camera off because it's more important to look at the slide than I. There we go. Okay, linking external data files to the Arkansas Healthcare Transparency Initiative data, which includes, as we just heard, the APCD data and the data that we receive from the Arkansas Department of Health and medical marijuana cardholder data, and sometimes Medicare. External file linking is a supplemental process available to data requesters that enables the association of HTI data with an external analytic file based on a study ID match. Periodically, it's happened, I don't know, 6 or 7 times over the years. A data requester has a file of data that they need to append HTI data to for their study. And while this can be done and has been done, it is not a standard output because of its complexity. When you purchase data, you purchase it from the Arkansas Insurance Department. Any additional processing such as this requires an agreement with ACHI, as you can see in that second bullet. The external linking projects utilize either the re-identification approach or non-re-identification approach. These cannot be combined. The re-identification, if re-identification is required, there must be signed participant consent. And with it, though, identifiers can be returned. The next slide has more detail about this. This is just to provide the base definition. If re-identification is not required or consent cannot be obtained, identifiers cannot be returned with the data. In other words, you cannot be able to, if your data, if your analytic data that you want to match to the claims or the APCD or anything, if you will not be able to, you should not be able to associate that original data file back with the claims if you can't get consent, or it may not be required, but don't worry, that sounds like it's a non-starter, but it can work, and let me explain. Okay. So there's a lot of emphasis on this term re-identification. Act 1233 of 2015, this is the act that mandated the Arkansas All Payer Claims Database, and the subsequent legislation that enabled us to acquire the health department data also has this rule, this requirement. It prohibits the re-identification of individuals using HTI data, meaning, and you'll recall, we've talked about this many times, how we don't have personal identifiers. We don't get name and address and social. What we have is our hash ID, which creates our study ID. And that's what we link across data. So that mandate, that restriction extends to any project that uses these data. So if you have an analytic file that has name and address or name or something, and you need to append the claims to it, there are ways to enable that, whether we mask certain data or you obtain consent. Second bullet there, again, if re-identification is required, special consent must be obtained. The data requesters must use a specific consent form approved by the HTI board and the Arkansas Insurance Department Commissioner. The form is required to maintain consent documentation subject to audit by AID. Now, if you look in the blue box, you can do the consent form as a standalone document, or it can be included in the requester's research authorization form, which is required for researchers with IRB approval. So we have had in the past a project or two where the PI had their own consent form and got consent from all the participants, and then came to us and said, oh, I have consent. But that consent form did not contain the appropriate wording that was required to enable this to happen. So what they had to do was, I don't remember, they either had to go back and get consent on the new form, or we worked with the Arkansas Insurance Department to enable that consent form to work. I don't remember, but regardless of what happened, there hoops had to be jumped through to make that happen. So if this indeed you need to do this, get the consent form designed for this process. So let's look at a process map. Sometimes this illustrates the process and the requirements and the nuances better. Excuse me. All right, so you have a project, and for whatever reason, you need to be able to keep the identifiers. You need to be able to know who your study population is by specifically. And what you would do is, and you need to link it to claims. You would submit a data request through the normal process. And in your project description, you would articulate very clearly the need for re-identification and all of the conditions thereof. And you would that would have to be reviewed and go forward decision made that the project was sound, that re-identification does seem like it's appropriate. And if you get that, then you get your consent form, and then you go and get your consent. Now, we have in the past, we've experienced this, and sometimes it takes a minute. It takes a long time. One project took a year to get consent for all the participants. So be aware of that. If you think you have a project that requires this, then you need to have enough time to get the consent. And once you have all of your consent, and of course, all of your study participants, not all of them are going to provide consent. Well, you cannot include them. Or you cannot put them in the linking process. Absolutely not. So then we would finish the data request, because if for some reason you couldn't get enough consent, and you couldn't move forward with your data request, then we need to give you an out. So then you would move forward with agreements. You would purchase the data from the insurance department, or then you would engage in an agreement with ACHI to append study IDs to your consented data. Now, if you are operating off of a subscription like ABI, the purchase of data is already done. And then the agreement with ACHI, and the consent becomes a little different, but there is an avenue to do that. And there are probably some people on the phone today, on this call today, who have done that. So we have all of the agreements in place. We have the payments in hand. And then ACHI will receive and validate the external data, append the study ID, link up all the claims and member data, create the data package, and send it back to you. And with that, you would have all the data that you sent and the study ID, and you could link it to your external data. And you would have the permission and the permissions to be able to deal with your study participants directly. In all the time I've been here, I've only ever actually done this once. Now, the next process we've done many times. So let's talk about that. Let us say that you can't get consent, or your external data file doesn't really meet it. It doesn't have all of the, you don't need to know who the people are. So a similar project, get your data request in, explain it, what's going on. You don't have to go get consent. But what will happen is that once the agreement's in place with ACHI and with AID, and then we'll get the external data file. We will apply the study ID. We will link and collect the data. In these cases, what we will do is ask for you to send on your external file all of the data you need for your study, because what we send back to you cannot be linked back to the data you sent to us. All those links have to be broken. And so that it complies with the re-identification mandate in Act 1233 of 2015. So let's say your study file has 50 fields, and 5 of them have the necessary data for the study ID. What we would do is we would append the study ID to the 45 of those fields, masking whatever we need to mask, and then package all the data and send it to you. And we would lop off we would not include, that's a very generic term, lop off. We would not include any data on that source data that could link back. And we would also mask the study ID so that it is associated with your project alone. We can't link it back to APCD. We can't link, or the ACHI copy, or any other copy. Much like when you order data from ResDAC, when you order Medicare fee-for-service data from ResDAC, the Benny ID is masked to your project specifically. That's how this will go. So you can see the asterisk comment there, output data cannot include source data or linking keys. You cannot link it back. And we have found that this works pretty well. It works pretty well. There are not that many studies that really require linking back and actually knowing who the person is. Most all of our projects are this way. And again, there are 2 agreements, so be prepared. It's not one agreement that you sign and pay. It's 2, and one of them is with AID, and one of them is with ACHI or UAMS. So, does anybody have any questions at this time about the link? Has anyone used it and has a caveat or recommendation. Oh, wait a minute, check the chat. No one. Okay. Let's see here. Okay. Ooh, my apologies. Okay. Well, if you think of something, or feel free to put it in the chat, and we will, so we can move forward. Happy to have all of your opinions. Okay. The next section, I mean, and we are moving along, is data use cases from other APCDs. So I've done this before, included some of these. Massachusetts has a really robust data users group, and they always have good examples of questions that they are asked by their users. However, their data is, every APCD has slightly different data. And so the examples that I looked at from them, I thought I'd go a different path. So what I decided to do was showcase some dashboards from other APCDs. One of Arkansas's goals, hopefully someday, is to have our own dashboard. But so in the meantime, let's look at other states' dashboard. Plagiarism is very complimentary sometimes, but these could be valuable to you because they might, all of the data in these APCDs is structured basically the same, and of course it's claimed, so they're answering many of the same questions, but you can see how they slice and dice the data. And if you go to these sites, you can get methodology off of them. And while some have differences, there are quite a few that are exactly the same. So I thought I would showcase. Now, to do that, I'm going to stop sharing for just a moment, and I am going to share something else. Okay. Is everyone able to see my screen that has Civic up here and says Shop for Care? Yes? I see. Thank you. Thank you, Tanya. All right. This Civic, the Center for Improving Value in Healthcare, this is Colorado's APCD. And we're just going to show off all the websites first. And it has some preliminary setup information, but the fun stuff is down here. And so they have this Shop for Care, and most of these APCDs, dashboards are designed for the users to shop for care. Frankly, it's what do you need done, and where can you do it, and how much might it be? So Colorado has found that there are two big categories that they were able to provide information, useful information on: imaging procedures. And what you would do is you would find your imaging procedure, and I played around earlier. And so this is an MRI for an arm joint 73221. This is the zip code. I don't know where that is in Colorado. And then you have several things to look at. You have, go down, the facility name, the distance from that zip code, the average price, price range, patient experience, where it's available. And I cannot speak to how they did these calculations or measured quality, but all of that methodology is within this dashboard. So you can see a person might think twice about going here versus here. I don't know. But it's interesting how you can get the quality in there as well. So let's look at other procedures. Bariatric procedure, breast biopsy. Let's do that. Again, same structure. Excuse me. And this one adds a layer, pre, during, post, and some quality, same thing. So these data are rolled up for some infographics, but and you can download the data as well. from this one. That might be helpful to you in whatever project that you. So this one again is Civic. It's the Colorado APCD. When the link for this is in the deck. So after this webinar is concluded, you'll get that in your email and you'll be able to get quickly to this. And I recommend that you join their mailing list because Colorado does a lot of really good things, really interesting things with their data. Okay, let's see here. Let's go to the next one. This is Compare Maine. Maine was one of the first to have a pricing dashboard. And it's very similar. You can see across the top, there's a whole section on methodology. Find a cost of a procedure. Let's see, we had looked at MRI, arm joint. And they have a slightly different look, obviously. They worked with their population and their users to determine the best way to present these data. And let's go here. And oh, sorry. Cost breakdown that gives you some more methodology. 50. Oh, look at that. 15 procedures or services were used to calculate this estimate. You can see. So at the highest level, this may look, you know, okay, maybe it's not terribly useful, but when you start looking at the methodologies and the services and procedures that were used to identify these events, then that could be helpful to you in building your projects. All right, let's do another one. If I can, oh, okay. This one is New Hampshire. And it has a level that's very interesting to me because the other two APCDs did not have this layer, but in New Hampshire, I had gone ahead and gone this far. They ask for the insurance carrier because if you're doing work on cost of care and out-of-pocket expenses, etc., that can make a difference in what you're looking at, the type of carrier. So in New Hampshire, they have the three big ones, and then I do not have medical insurance. So let's just do entire state search. I don't know what a zip code is in New Hampshire, but you can see it provides basically the same thing, though it doesn't talk about, well, here's quality of care over here. Sorry about that. I'm not going to go, that's a little deeper. So let's just look at numbers. But it gets similar things. And so if we select one, you will get some information about costs of things in that particular facility. So there are lots of levels, and I wanted to provide this insight to you to give you a perspective on what other states do and what might be available to you. So let me stop sharing for a second and reshare and go back here. So these are the slides that would have preceded those websites. Colorado APCD, there's the link, Maine, and New Hampshire. So I explore them, and if you need to find, yes.
Yes. I'm not able to see anything right this minute.
Did
you perhaps close it?
How about that?
Yes, so once you close the website, we didn't see after that.
Okay, so it's right here. This is where I started. Right. Thank you, Claire.
Yeah.
So these are the slides for the three websites that I just showed you. And if you find something that on those websites and you have a question about, all of them have an info link, but I can certainly help you find a contact at any of these states if you need it. Okay. All right. A regular section in our data users groups, our latest release information and data tips. And since the last one, we haven't had a new release. We still have the database that's available to you now has officially data through March 31st, although I can tell you there are some carriers that have data through June. will begin the next build next week, and it'll be available in the spring, and it will have data, as much data as we possibly can get through December of 23. So we're moving along. The data, the release notes, the universe counts, and the tip sheets, etc., that are linked here have not changed. Well, tip sheets have. We're going to go over some new ones. But I wanted to give you a little bit of a teaser. In our next release, we will have new Medicare fee-for-service data. So, one moment. The Arkansas HCI APCD, we're not a qualified entity with CMS. Therefore, we can only release Medicare fee-for-service data to named state or related agencies like the Health Department, DHS, UAMS, ABI. However, I know that many of our data users are from these agencies and participate in these calls, so I thought I'd do an early announcement and talk about that. If you are not a state agency and you want Medicare data to link with the Arkansas All-Payer Claims Database and HTI data, then talk to me offline. I've never done it before, but there is a potential way to do it with ResDec and CMS. But for those users who have access, I wanted to let you know some new data was coming. Note, Medicare data is always a year or two or three behind. We have had 2020 data for about a year now. 2021 is scheduled, as we said. However, let's give you an early look. I wanted to take you to this link because I don't know how many of you use the data, but it's always helpful to look at the data again. Let's see here. And I'm going to reshare a different screen, and I promise to hit share. Totally promise to hit share. Okay. You should be seeing a screen, yep, that says Arkansas Medicare Data Dictionary Resources. This is on the Arkansas All-Payer Claims Database website in the Understanding Data section. The link is here on the deck that you will receive. And it gives you some very helpful links and documents that I've downloaded that will help you use these data. Now, the Arkansas Medicare Data Dictionary Element List is what I'm going to show you next, because if you've used Medicare data, or even if you haven't, or maybe I should say it that way, if you have not used Medicare data, it is a complicated thing. So you should be seeing a spreadsheet with a red bar across the top. And these are Medicare data. Medicare data is fee-for-service, is not in the APCD format. It comes in many tables that are grouped by category. Here's an example. Let's see here. I'm going to highlight these right here. The abbreviation HHA stands for home health. And so this represents 7 tables that have information about home health services paid for by Medicare, traditional Medicare, fee-for-service, not Medicare Advantage, Medicare. And ResDec, CMS has, it's a tried and true process for them. They group types of data together and provide them in different files. So the one that is entitled HHA_CLM, those are all of the claim lines. And then you can see condition codes and facility providers, occurrence codes, revenue codes. This column C on this spreadsheet has a high-level description of what these are. And all of these tables link together either by the claim number or the Benny ID or something. And at the bottom of this spreadsheet, you'll see many, many tabs. And each tab is associated with one of these tables, so you can see what tables are in there. This one right here is HSB is hospice. INP is inpatient, and you'll look over here in column D and it talks about it here. Outpatient, SNF is skilled nursing facilities. Now, worry not, we also have carrier claims, this is professional visits. And then Part D, pharmacy claims, and of many, many other supporting tables. I thought since I had you, we were talking about Medicare fee for service. I wanted to share this with you again. It's always helpful to look at this spreadsheet to determine what type of a data is available. And all these data are from 2013 through 2020 right now, and we're about to get 21. Okay, I'm going to go back to the deck. Coming soon. All right. Excuse me. So with the 2021 data, we're going to have some new tables. And the most exciting one is the first one, the Medicare beneficiary chronic conditions data through 2013 through 21. And this is the word data has a link to the CMS page that describes it. We also have it on our Medicare data page. The chronic condition warehouse provides researchers with Medicare and Medicaid Benny claims. It's Medicare for us. I copied this. And assessment data linked by beneficiary across the continuum of care. It will help you immensely as you use Medicare data to roll up information about at the beneficiary or Benny level. So again, this link takes you to more detailed information about that. And these data will come out, be available in the spring. There are some more new tables. We have several demonstration tables, demonstration project tables, and demonstration projects study the likely impact of new methods of service delivery coverage, of new types of service and new payment approaches. I'm not certain how you would use them yet, but they will be available if needed. They're fairly small. Let's see, the next one. We have two more. The Medicare Part D indication-based formulary data. This is interesting. It provides additional information about pharmaceuticals using a formulary management tool that allows health plans to tailor on formulary coverage of drugs predicated on specific indications. These data link to the Part D claims on formulary ID. There's a link here. It takes you to information on the CMS website about it. And the next one is the Medicare Part D senior savings model. Again, the link will take you to the CMS page about it. But this is interesting to me. Medicare Part D senior savings model tested different approaches to Medicare gap coverage. The model is aimed to reduce Medicare expenditures while preserving or enhancing quality of care for beneficiaries. This table contains line level information about pharmaceuticals and their Medicare contracts to which they are associated. It's trying to help deal with the gap, depending on the coverage that you have or your spend, there's a gap that Medicare won't cover. All right, the next is these are existing tables that will have new data elements. All of these layouts, the spreadsheet I just told you is current state. All of these layouts with the new tables and the new fields will come out with the new build. We'll let you know probably in a data tips email, and all the new things will be noted so that you will be able to see them. But we have, if you recall the structure, like we will have new fields for home health claims, home health revenue data. DME means durable medical equipment. So something to look forward to. Okay. Don't forget, at the beginning of every project, when you have your data, look at your data tips. Don't hesitate to talk to us if you see something odd in the data or you see a data tip you don't understand. But we do have some data tips to talk about. Excuse me. In the last build, I guess the one that's up now, we appended data to a field that already existed. It was called ME001_CAT. And you'll see at the bottom of this page, there's a refined field. There it is. We called it type of coverage, but we're changing the field name to payer type. But we introduced a new value called PBM, and we have begun instructing, I actually got things a little mixed up. We've begun instructing carriers who are truly providing claims for PBMs to put that in here. Let me stop a minute and fix what I just said because I made a mistake. We have a code. It also works with payer type called the insurance product code, ME003, MC003, PC003, etc. Anyway, so we have a new code, PBM, and we've asked PBMs to put that code in there if the claim that they send is truly for a plan managed by PBM. This code does feed ME001 CAT, and we've changed the name. Sorry for the confusion. Okay. Hyphen and ME992. ME992 is the HIOS ID, and it's used in when you are segmenting by qualified health plans or plans on the exchange, and there were some that had hyphens in them, and the hyphens have been removed. Using Caremark data, if you click on this tip, Caremark is a big PBM, but they also do some work for just as a provider, a pharmacy insurance provider. So this link will help you differentiate that and understand some of the nuances. Incorrect race code assignment. We discovered that in the qualified health plan carriers for Centene and Call Choice, they had an error in how they assigned Asian to the race field. They had a disproportionately large number of individuals flagged as Asian. And we have worked with them, and they have identified the problem, and they are submitting corrected data. But right now, if you have to use race, go into this link, and it will give you the submitting entity codes that you need that have this issue, and you can deal with it that way. All right. Okay. As always, reach out to us if you have any questions. Now then, does anyone have an idea for another data users group? Is there anything in this one you want to explore further? I can, let me see if everyone is, I can unmute everyone. No, everyone says mute. Huh. You can unmute yourself, I guess, or put it in the chat. Periodically, I will get invites to classes put on by RESDAC, the Research Data, RESDAC, the Research Data Center. That's the group that processes Medicare data for sale. And they have a lot of classes on how to use the data and how to interpret the data. And they have a lot more data than what I have shown you. And so the next time we have a data users group, I will try to include some links to them. If you can get on their mailing list, I highly recommend that you take their classes. They're very informative. All right. All right. So we are early. I thought we'd be early. Let me get here. Sign up for the newsletter. Our next data users group is April 24th. And don't hesitate to reach out to us with any questions or subjects or projects that you would like to show. I may reach out to you and ask if there's a project that you would like to show. With that, if there's nothing else, I will give everyone 15 minutes back. Thank you so much. Bye all.